First of all, I want to thank Dr. Vaishali for this opportunity, and it is wonderful to be sharing the stage with such stalwarts. Now, my topic is visual rehabilitation following pediatric cataract surgery. So I call this the next 5 years after the surgery is done. So achieving a good vision outcome, it requires an early surgery, early removal of the cataract, as we have learned, consistent optical correction of the aphakia or the residual refractive error, and compliance in occlusion of the other eye. So as we've already heard from Sir, IITS was a multi-centric trial comparing aphakia with correction with contact lenses with intraocular lenses in infants with unilateral congenital cataract less than 6 months old at 5 years, and now we have the 10 years results as well. The visual acuity final results were quite poor, with about 50% of eyes having a poor visual acuity of less than 20/200. They also had a high incidence of complications in the IOL group. Now, comparing this with Dr. Vasavada's study in bilateral cataract surgery, as expected, the visual acuity recovery was much better, with the children having a moderate visual impairment of 20/60 to 20/80. But one thing which was different was the contact lens acceptance and compliance, which was extremely poor. So that gives us an idea on what kind of refractive devices work in our clinical setting. So either aphakic or pseudophakic amblyopia therapy starts with refractive correction, which happens with glasses, contact lenses, or a secondary IOL, as has been described in detail. So spectacles provide satisfactory correction for bilateral aphakia. The material which we prefer is CR39 or polycarbonate. Near dominant glasses need to be prescribed up to 3 years of age. And at this point in the last photograph, I also want to point out that many of these children have multiple systemic issues as well as hearing issues. So they wear hearing aids, they have cochlear implants, so a high powered aphakic glasses for rehabilitation may not be practically possible. This child is wearing an ear suspender in order to keep the hearing aid in place. So these may be considerations where we may decide to implant an IOL instead of leaving a child aphakic. Contact lenses are really good optical devices, and I feel that the parents have more of an apprehension than the child, who's usually really comfortable with the contact lenses. We tend to use them in our anisometropic amblyopes as well, and if they get used to it, then it works extremely well. The extended wear silicone elastomer lenses are what we go for in the RGPs for those where that is not acceptable or it's too expensive. With primary implantation of IOL being done in even the youngest children, with a planned undercorrection of about 6 to 8 diopters, so that almost all of these children are going to have a high amblyogenic residual hyperopia. So again, in these children, we need to give near dominant glasses in ages less than 3. And bifocals or progressive lenses, again, the acceptance rate is quite good over maybe 5 to 6 years of age once they learn how to use the near segment. As emphasized previously, routine EUAs are extremely important in the follow-up of these children. So coming to the main crux of this talk, patching as a therapy was first described by Al-Harani in 980. So basically what we want to see is where have we come from then in the past more than 1,000 years. One thing to emphasize is that children with cataract have stimulus deprivation amblyopia, which is less than 3% of all amblyopia. And as such, there are no RCTs conducted describing the effectiveness of various amblyopia therapies in stimulus deprivation amblyophias. It's usually excluded as it's considered more severe and resistant to treatment. Patching still continues to be the gold standard in occlusion therapy, with an adhesive patch with total occlusion to form and light being recommended. The IITS had a pretty rigorous regimen of 1 hour per day per month of age. So you would patch a 6-month-old for 6 hours per day and 50% of waking hours after 8 months of age. In bilateral amblyopes with a milder form of amblyopia, the ATS recommendations of 2 to 6 hours of patching with near work can be applied. In children who are extremely resistant to patching therapy, atropine penalization combined with optical penalization can be tried in slightly older children. But in our clinical, again, with follow-up being an issue, some chance of atropine having side effects, this tends to be the second option for most of us. So coming to compliance with patching, as has rightly been said, whether we prescribe 6 hours or 10 hours or 12 hours, we really don't know how much patching is actually being done. Even in the amblyopia treatment studies, it is prescribed patching versus the patching which the child is actually getting. And several studies have said that this averages less than 50% of the prescribed hours. And the more number of hours you prescribe, the less the patient tends to patch. So if you prescribe 6 hours, the child is getting 2.5 hours. If you prescribe 12 hours, child may be getting 5 to 6 hours. So some recent suggestions are that educational intervention, so a counseling session with an orthoptist along with cartoons to actually explain to the child why the patching is being done, regular follow-up with rewards, really helps in improving the compliance. The occlusion dose monitor is a new device which is mainly used in studies to now determine the dose response ratio. But these are basically thermal sensors which are embedded in the internal and external surface of the patch to accurately determine the duration of the actual patching which is being done rather than the prescribed patching. So newer therapies, again, I want to emphasize that the newer therapies, it's all for children who have maybe moderate amblyopia. When we go into the really severe amblyopia, eccentric fixation, these are not in consideration at all. Since Dr. Vaishali asked me to take names of some companies, I have to declare that I have no financial interest. The three most common types of therapies which are in use now are perceptual therapies, dioptic therapies, and virtual reality is upcoming. Perceptual learning is based on the principle that practice makes perfect. So basically, you have repetitive practice of software-based visual tasks, and this improves the visual performance by inducing plasticity of the visual system. These can include, targets can include Gabor patches, vernier acuity, and letter identification among noise. One of the companies is FDA approved, and they all claim really good results, but they are very small studies with a short follow-up and less number of patients to really declare that they are very effective. But they claim a 2.5 line improvement and 100% improvement in contrast. One of the main complaints is that the outcome measures, the improvement happens only for the particular activity for which the patient is trained and doesn't translate to real life. So some of the activities which happen, this is Revital Vision, which is currently available in India, both for office therapy and home therapy. So the activities may be like, which is the darker patch among the two, which of these patches is shifted, which of the patches have 3 images, or which of the squares contains the patch, and so on. So as you can see, the tasks tend to be quite boring. So for children, the acceptance rate I found practically is quite low. Coming to dioptic therapy, now perceptual training is mainly for the amblyopic eye. It is monocular training. Dioptic therapy believes that amblyopia is mainly a binocular vision problem and should be treated as a binocular problem and not just the problem eye. So unlocking the binocular visual function by presenting an independent visual stimuli to each eye, requiring integration in the brain of the 2 images. The image shown to the amblyopic eye is of higher contrast to compensate for the decreased contrast sensitivity. And as the vision improves, the contrast also improves or increases. So they are fun, they're of shorter duration, there's no patching involvement, so definitely the acceptance is better. And now we have some dioptic movies also which are available, popular movies available in a dioptic format, which can just be passively viewed. So one of the systems which has been used for some time, and Shankar Netralaya also has this, is the Vision Therapy System 4. It provides dioptic targets, which is a different target to each eye, using a stereoscopic TV with liquid crystal shutter goggles. The goggles turn transparent to opaque along with the target. It's synchronized with the target. And as the visual acuity improves, the targets become progressively smaller. I think the acceptance rate of vision therapy system, there are very few of them around in India, is because of the cost. And also these, the goggle is extremely delicate and quite expensive, tends to get damaged quite easily and is difficult to replace. Doesn't translate very well to home therapy. So, but based on the VTS, we have a number of homegrown dichoptic therapy and games which are now available. These are two of the companies I've named. These glasses, the anaglyphic glasses, red-blue glasses, are easily purchasable on Amazon. This particular game, which has been studied quite a bit, is called Digrush. And basically, a red target is provided to the right eye, a blue target to the left eye. And the game you can proceed with only if you're able to view both the targets simultaneously. The background tends to be neutral, which is viewed by both the patients. So this is an adaptation. This patient is again wearing the red-blue glasses, and red target is being provided to stimulate the right eye. And finally, coming to virtual reality vision therapy, which is all the buzz right now. There are a couple of companies which are providing this in India as well. And it's gained a lot of commercial interest. So in this, unlike in dichoptic therapy where the eyes are separated using red-blue glasses, in this they're separated by contrast. So the stronger eye is provided a target with lower contrast, and the weaker eye is provided a target with higher contrast. And you have to use both the eyes together again in order to play the game. The background remains the same, and the contrast is equalized between the two eyes as the vision improves. So this is a virtual reality headset. And these games are interactive. So we know that some of the older studies have also studied levodopa in amblyopia. So it's said that endorphins may help in improving the neuroplasticity. So these games may be releasing endorphins because you're actively involved. They are shooter games, and we know video games, provide a high. So that may also be helping with the improvement. So these are all newer avenues towards amblyopia therapy. But and finally, I don't want to conclude without, so Dr. Santan Gopal has developed his own amblyopia treatment device, which has an inverse principle. It believes that we need to start stimulation from the cortex and not from the eye. So his device basically consists of these LCD lights, and with a central red light and surrounding white lights. And the therapy is short lasting, it's only about an hour. And it consists of initially moving the eyes to identify which light is glowing. And in the second part, it consists of focusing on the central red light while trying to count the peripheral lights which are lighted up. So the saccadic movements basically help in activating again the cortical response. And he's reporting very good results with the same. And I would like to conclude that again to emphasize that these newer amblyopia therapies may be useful for children who are cognitively normal and who have good hand-eye coordination. But a lot of children with bilateral cataract have multiple other systemic problems. A lot of them have CVI as well. So our rehabilitation, in the majority of children tends to be more traditional, involving patching, involving combined and coordinated use of medical, social, educational, and vocational measures to bring them to the highest level of functionality. And with that, I conclude my talk. Thank you.
Thank you so much, Dr. Varshini. That was very enlightening and informative, and I must dare say that it was not boring at all. But I think, what I understood and why we wanted to discuss this is that now, like we are moving ahead with surgery, with techniques, with understanding, it is also time that once we start talking about newer technologies, like you said, everything may not be translatable today to every scenario, but this will get us thinking, and in that direction, and with the AI and so much more new technology coming in, I think we need to think of better and more user-friendly alternatives for children to patching.
No. So many of them are very user-friendly, and I think most of us have started offering it clinically as an alternative now. For older children who have failed patching. So this, as it requires a lot of hand-eye coordination and concentration, so children older than 8 to 9 years, we start trying them out when we know patching is not very effective anymore in that age group, if it has been tried properly at a younger age. So we are practically using this in most of our clinics now.
Absolutely. So I think this is very valuable information for all our attendees as well. Any comments from any other panelists? You need to unmute yourself. You're muted.
I have a question for Varshini, very simple, basic question. I used to believe that you cannot prevent or develop the vision after 10 years of age in an amblyopic eye. So what is the age that you give up, that now there is no hope, or what is a message to the person? Because some people say, it's not going to work after 7 years, some say 10 years and 12. What's your take on that?
So my take is now it depends on the motivation of the patient. So I explain the options to them, and it depends on how much motivation they have to try. I tell them the options, I tell them the studies, and I have a lot of older patients as well who have improved by say 2 lines. Again, whether it makes a practical difference to them is the question, but objectively there is an improvement. And in children who are diagnosed late, then I don't have an age cutoff, because I have like 14-year-old children diagnosed with severe anisometropic amblyopia, maybe with a +6 hyperopic error, who have improved extremely well with glasses, patching, and these exercises. They even come up to 6/9. So yeah, in older children, I don't think we have any reason to deny them the treatment. But of course, treatment is much harder because the motivation levels are much lesser by that age.
And the improvement that you achieve, does it remain for a long time or ever, or what is it?
So I have a couple of patients. I mean, since these are relatively new techniques, we've been following them up for about a couple of years, and we find that it is sustainable.
Very good. Nice. So we'll try that. We'll remember this. Very good. And the one which Gopal, Santam Gopal had playing with the cortical cells, is it available in the market?
Yes.
Or is it his own?
Yes. No, it is available. It is being marketed. I don't have any personal experience with it, but since he reports really good results, I want to ask Dr. Sumita ma'am her take as well, if they've managed to try it.
Because it sounds, it makes sense what he's saying and doing. Very nice. Okay.
Dr. Sumita, your experience, like Varshini said, with this new device from Dr. Gopal or any other thing?
Actually, I have not seen this device by Dr. Gopal, and the paper which he published in IJO had a mix and match of various types of amblyopias. There are no pre-treatment visual acuity and post-treatment. How much was it in actual terms? So there is a gap in time. Probably he wanted to rush through the publication, but if it
also
is
the initial visual acuity was very good in this paper.
In this paper visual acuity was
they were already 612 or so initially. So very difficult to make out really if it is really working. And so I'm going by what he has published in that paper. I have no personal experience. I have not seen him. But if it is working, it is self-evident and it will become popular, and it should. The principle seems to be all right in its place, that amblyopia is a cortical phenomenon and you can work it the reverse way. But what evidence is out for us to review probably needs little more. I mean, somebody else should report similar results before we take it. So yeah, I think there is some time before we can say, it's definitely working. But idea sounds good, and I have no objection to trying it out if